Today, Professor Robyn Lucas will be talking about getting the balance right between skin cancer risk and vitamin D production. Robyn is a medical graduate with a PhD in epidemiology from the Australian National University. She's a Fellow of the Australian Faculty of Public Health Medicine and holds a Masters of Higher Education and a Masters of Public Health and Tropical Medicine. Robyn was the lead author on the global burden of disease due to ultraviolet radiation assessment for the World Health Organization and is a member of the United Nations Environment Programme Environmental Effects Assessment Panel for the Montreal Protocol on Ozone Depletion and the International Vitamin D Standardisation Programme. Her work examines the risks and benefits of sun exposure, with a particular focus on immune function and autoimmunity, and unravelling the possible independent effects of sun exposure and vitamin D. And today Robyn will speak about this area of her work. So we really thank Robyn for her support, and we're delighted to have her here to talk about skin cancer and vitamin D getting the balance right. Would you please join me in welcoming her, please?
Thanks, everybody. Well, I'm delighted to be here, particularly because it was less than 10 degrees maximum in Canberra yesterday. So even though it's not a very nice day here, I think it's actually a lot warmer than it was there. I hope you haven't come expecting me to have all the answers, because we don't have all the answers. So what I hope I'll be able to do is offer you the evidence that we have and some assessment of, as far as we know, the best way of getting some balance between the risks and benefits of sun exposure, particularly for us in Australia and specifically in Western Australia, where it is very sunny. So this is our question: to UV or not to UV? That is the question. See, he's not even really under the sun. So to understand a little bit about getting those risks and benefits right, we need to understand a little bit about what the sunlight that's coming into Earth's surface, what its composition is. So these two lines here, this is the sort of wavelengths of light that are coming in from the sun. And we have the visible light here. So when you see a rainbow, that's what you see, is the visible light that's all around us being broken into all these different wavelengths. So that's what we see, and that's just because that's what our eye sees. So some animals can see ultraviolet light, but we can't. So then we also have these longer wavelength infrared, so below the red, that's heat, that's what makes us feel warm. And then we have the ultraviolet, which is the wavelengths that are shorter than the violet end. Our ultraviolet is divided into UVA, UVB and UVC. Again, it depends on the wavelength, but we don't get any UVC at Earth's surface, and most of the UVB is filtered out by ozone. So when we were worried about ozone depletion in the 1970s and the 1980s, what we were worried about was getting a lot more UVB. And we were worried about that because UVB is the most biologically damaging. It doesn't penetrate very far into your skin, but that's the type of UV radiation that causes mutations in DNA and is the primary cause of a lot of our skin cancers. So when we think about risks, we're thinking about the areas of our body that the sunlight can actually reach. So when we get UV radiation to our skin, we can develop these skin cancers: malignant melanoma, the non-melanoma skin cancers, basal cell carcinoma and squamous cell carcinoma. They're just different types of skin cancers, come from different cells, and I'll show you a little bit about that in a minute. This is the most common of the skin cancers, basal cell carcinoma. More than 40% of them arise on our face and our neck. They're reasonably easily managed, but they can be very disfiguring. I'm a New Zealander, and I worked in medicine for a while in New Zealand, and some of our Scottish ancestry, very, very fair people, farmers who have been out on the outside all of the time. I won't describe to you because it's probably not an appropriate audience to describe exactly what some of those people can suffer from multiple and recurrent skin cancers, but it's pretty horrible. So even though they're tend not to be lethal, they don't kill you, the basal cell carcinomas particularly, they're not great. You don't want to have them. Then, as well as the skin cancers, we get actinic keratoses, which you'll often see in elderly people, sort of dry, puckery bits around their face and on the backs of their hands. They are not skin cancers. They can turn into skin cancers. Sometimes they just disappear, but they're a sign of sun damage. Photoaging, I think all of us in Australia that have lived here for a while will have some degree of photoaging. What I mean by that is the sort of wrinkles that you get, and when you pull the skin up on your hand, the way it doesn't pop back like a child's skin would pop back, it sort of stays in that slightly wrinkly, elastic-free sort of way. Photoaging is actually, while these things are largely related to UVA and UVB for malignant melanoma and basal cell carcinoma, photoaging tends to be mainly a UVA effect, and it's from the sort of deeper layer of the skin, and the UVA destroys our elastic fibres, which is exactly why it doesn't spring back like it used to. The other, as well as the skin, we get, of course, the eyes exposed, and you get cataracts and a range of other things. And actually, UV or sun exposure to the skin suppresses our immune system. And that's very nice for our skin cancers, because our immune system, one of the jobs it does is it looks for abnormal cells and it destroys them. So when you get sun exposure suppressing the immune system, it actually is also allowing some of those skin cancers to develop. So it works in these two different ways. I'm going to focus today on skin diseases as the main risk. And what I really want to tell you is what's been happening over the last 20 or 30 or 40 years in relation to skin cancers in Australia. So I said I'd just talk about where these different cells come from. So this is our skin. This is really just the top, maybe 1.5 millimetres of skin, so it's very thin. We have this sort of dead cells on the top, and those get sloughed off from, they just normally fall off and new cells are produced. The basal cell carcinomas arise from this very bottom layer of what's called the epidermis, the very purple ones. Melanocytes are the ones that produce our skin pigment, the melanin. That's where melanomas arise. And then squamous cell carcinomas arise from these other cells, which are called keratinocytes, and those are also important for vitamin D. So that's a name just to keep in the back of your mind that we'll come across again. So what does UVA do? It causes damage to the DNA, causes mutation. UVA causes oxidative stress, so free radicals in our skin, and these together damage the cells that can then go on to form a skin cancer. So these are some data from people, adult Australians from the East Coast, and what the graph shows is for people, so these are the different colours, are people born in different decades. So the red's people born in the 1940s, yellow 1950s, and so on. And what they did is they reported how much time they had been in the sun at different ages. And so we can get a picture over time of what people's sun exposure has been doing. And as you can see, it's generally, this is sun exposure during leisure time, so weekends and holidays. People are getting less time in the sun than they used to. Partly, of course, this is an ageing effect, but you can see over the whole population, even the younger cohorts are not getting as much sun as we did. And I was just been recalling my time when I was growing up in New Zealand, where we, every summer, our noses peeled many, many times. We used to see who could get the biggest piece of skin peeled off the backs of our backs through the sunburn. I mean, I have adult children. That's way, way away from anything that they would possibly imagine. It's just completely, times have changed, thank goodness. Sunburn's not quite so good. So these are data from Melbourne. And what they've asked over successive surveys, they've asked people on the previous weekend, so this is adults, I think over the age of 14, they're not really adults anymore, but from people 14 and up, whether they've had sunburn in the previous weekend and how much they've used sunscreen. And you can see that people started to use sunscreen more in this early period, 1994, 95, and then it sort of drifted off a bit. So we had big gains in people using sun protection, but then it hasn't really been maintained that we have those big gains. And the same thing with sunburn on the previous weekend. It was getting less. That was great. Fewer people reporting being sunburnt, but it sort of drifted up again. So how does that translate into skin cancers? Well, before we get onto the Australian data, I thought I'd show you this data from Denmark. And because they've got some of the oldest records, so right back to 1943, and you can see that melanoma incidence has been steadily increasing. It's more common in women than in men in Denmark. But what I also want you to look at is the absolute number here. So less than 30 per 100,000 people, all right? So just hold that as we look at the Australian data. So these are the latest data from Australia, and you can see that there's a very nice, sort of very exciting, because in women at least there's a flattening and maybe a suggestion that melanoma incidence is decreasing in the last little while. Maybe not so good for men, but look at the actual number. So whereas in Denmark they're still going up, but it's 30 per 100,000, we might be levelling off or even going down, but in men our incidence is 60 per 100,000. So the trends are good, but the absolute number is still pretty horrible. Looking at Western Australian data, it's even better. Like there is a really clear downward trend in melanoma incidence for women from about 2004. We're starting to see the same downtrend in men, but we're way up here, close to 70 per 100,000. So while the trends are good, there is a lot of melanoma. Its incidence is much higher than it is in other parts of the world. This is now young people, 15 to 39, and you can see these trends are even better. So in these younger age groups, we're seeing this decrease in melanoma incidence. And this relates, we think that there's about a 15 to 20 year lag. The sun exposure that you get in childhood, and particularly sunburns, so that sort of high dose intermittent sun exposure, is particularly a risk factor for melanoma. So when we see people's sun exposure decreasing in childhood, about 20 years later, we're starting to see melanoma. 15 to 20 years later, we're seeing melanoma incidence go down. Now, the scary thing is that if that sunburn incidence is increasing like we saw in Melbourne, that we're not getting those gains anymore, that we have a nice down now, but if we don't keep vigilant about sunburn in our children, then we're going to see it go back up again. Non-melanoma skin cancer incidence is much harder. Non-melanoma skin cancers are often just destroyed by the GP. They're not actually a piece of tissue taken and sent to the pathology lab, so they're not properly diagnosed. There's no cancer registration for non-melanoma skin cancer. So it's actually really hard to get an estimate of the numbers. We think in 2008, there was about 430,000 new non-melanoma skin cancers diagnosed in Australia, but it's very much an approximation. This is actually non-melanoma skin cancers that have been removed. So they're from Medicare data, so using the Medicare item number for removal of a non-melanoma skin cancer. So they're sort of the best data that we've got, but it's not perfect. There will be some that are not recorded here. We see steady increase. Non-melanoma skin cancer overall in Australia is still increasing, but again we're starting to see these trends of decreasing incidence. So these in the older people, there's a change between 2000 and 2011, I think, where there's still increasing incidence of non-melanoma skin cancer, but in younger people we're starting to see that the incidence is decreasing. Where that lag period between the risky exposure and getting the disease was about 15 to 20 years for melanoma, it's probably more like 40 or 50 years for non-melanoma skin cancer. They tend to be diseases of older people. So we're probably not going to see marked decreases in these until quite a lot of time further into the future. So just to summarise our risks, time in the sun's been steadily decreasing over the past 30 years, but unfortunately that high-dose intermittent sun exposure, that risky type of sun exposure pattern that leads to sunburn, is not really decreasing in the same way that we would like it to. Skin cancer is the most common and most expensive cancer in Australia. 2 in 3 of us, at least, will have a skin cancer by the time we're 70. But we are starting to see changes in the younger age groups, and that's probably related to our sun protection programs. I was in New Zealand a couple of weeks ago. They're not seeing the decreases. They haven't had the decreases in skin cancer incidence. They haven't had the same investment in sun protection that we've had in Australia. And I guess we can thank the cancer councils really and for our sun protection programs that we're actually starting to see a decrease that most other parts of the world are not seeing. So moving on to some benefits. So everybody here knows that one of the benefits of sun exposure is vitamin D production. You only get vitamin D from the UVB irradiation, so the shorter wavelength irradiation to those keratinocytes. The other things that happen with sun exposure, it doesn't just affect DNA in your skin and it doesn't just affect the vitamin D precursors in the skin, but when you get ultraviolet radiation hitting your skin, a whole lot of other things are produced or are changes, and you get a whole lot of chemical changes that happen in the skin, and they can have quite far-reaching consequences within the body. So we get immune suppression, which was also an adverse effect because it allowed our skin cancers to develop, and it allows some of our viral infections like cold sores, it allows them to come back, but it also can have beneficial effects because it may decrease the overreactivity that you get in autoimmune diseases like multiple sclerosis. So we think that sun exposure to the skin might also be beneficial because it suppresses our immune systems. And as I said, there are other photo products that might have beneficial effects on health, and that's a very active area of research at the moment. So let me just take you through vitamin D production. Sunlight shines on this chemical here, which is in the skin, which is in the cell membrane of those skin cells, and the absorption of the energy from the UVB changes it into this vitamin D. That's still in the skin. The vitamin D is taken up by the blood. This vitamin D isn't active at all. It's taken up by the blood. It has to go to the liver, where it undergoes a chemical reaction to form this 25-hydroxyvitamin D, which also isn't active, but it is what we measure, so that's its main importance. But that needs to go to the kidney and undergo another reaction before it gets turned into the active form of vitamin D. And it's this active form which is important mainly for calcium balance, but I'll talk to you about effects of vitamin D in a bit. So we might ask, is vitamin D deficiency common in Australia? And there has been plenty of hype that says, yes, vitamin D deficiency is really common, even though we're the sunny country, we're all vitamin D deficient. It depends how you measure it, and there are a lot of different vitamin D assays, and they have very different levels of accuracy. And if you take two blood samples, or if you take a blood sample and you separate it into multiple aliquots or multiple bits and you send it to different assays, you'll get very different results. So one of the ones that we had, we sent it to one lab and it was 13 nanomoles per litre, and another lab said it was 78 nanomoles per litre. 50 nanomoles per litre is what we say we want people to be over. So at 13, you would say you need lots of vitamin D supplementation, and at 78, you would say you're just fine, and that was just an assay problem. It depends who we measure it on. So we can measure the general population, which is really the thing that we want to know, how many Australians are vitamin D deficient. But there's been lots of publicity about results from studies where they've reported high levels of vitamin D deficiency in people who have had a vitamin D test done by their general practitioner. Why did they have a vitamin D test done by their general practitioner? Because their general practitioner was worried that they were vitamin D deficient. So the results of those studies will show that a high proportion of the population are vitamin D deficient, because the GP was worried that they were vitamin D deficient. That's why they did the test. So we have to understand who's been tested before we can make some assessment of what proportion of the population are vitamin D deficient. It depends when we measure it. Obviously, there's a lot more sun around in the summer than in the winter, and where we measure it. So there's a lot less sun around in Canberra, and we're all very well covered up compared to other places. So we need to understand what our question is. Are we worried about vitamin D deficiency in winter or in summer, and in whereabouts? And we need to know what we call deficient. And this, you wouldn't believe it, but we're trying to talk about making sure that everybody has enough vitamin D. But as scientists, we can't come to any consensus about what is enough vitamin D. So a lot of people say 50 nanomoles per litre is what we need. But then there's a whole group of scientists who say you need 75 nanomoles per litre. So if I change the level at which I say below this is deficiency, then I'll change the proportion of the population who are deficient. So again, there's a whole lot of considerations we need to think about before we know what proportion of the population are vitamin D deficient. Just going to show you some more about some of those things. So these are samples that have been separated into multiple aliquots, and they've been measured by all these different types of vitamin D assays. And this one at the top, the open square, is supposed to be the gold standard. It's the one that tells you the correct number. So if we look at some of these, you can see that this one here, the correct number is, 90, but some of the assays are saying that actually it's only 60. So depending on which assay your doctor sends your blood to, you might be 90 or you might be 60. And you can see the variability across a whole lot of these assays. So I think we cracked this one. So the CDC, the Centre for Disease Control in the US, has now developed a standardised, accurate assay that all the other assays can measure themselves against. And so we can actually finally have everybody on the same page and everybody measuring the same thing with the same accuracy. So I think we've just in the last 6 months coming to a point where we can actually start to believe the vitamin D assays. Despite that, this is what vitamin D testing has done over the last 12 years. So even though we know that the vitamin D tests have been of dubious quality, say it nicely, the number of vitamin D tests has increased exponentially, and the amount that we spend on them has increased. I don't need to read that for you, but we are spending a lot of our health dollar on vitamin D tests, even though we know that a lot of our assays are actually not giving us very good results. How do we know how much is enough? Well, as I said to you, people say 50 nanomoles per litre, other people say 75 nanomoles per litre. There was a huge study done by the United States Institute of Medicine a couple of years ago. After their review of the literature, they decided that 50 nanomoles per litre, higher than 50 nanomoles per litre was all you needed. So we want everybody to be above 50 nanomoles per litre. If there is an association with these diseases, you can think about this as risk. So you get a decreased risk of breast cancer as you get an increasing level of vitamin D, but really after 50 nanomoles per litre, there's not much change. So it's vitamin D deficiency that is the risk. Getting higher levels above 50 actually probably isn't changing your risk very much at all compared to 50. The same with cardiovascular disease here. And the risks of disease, certainly the risks of the bone diseases associated with vitamin D deficiency are around severe vitamin D deficiency. I'll show you a bit more about that in a minute. So these are the best data we have. They're released by the Australian Bureau of Statistics about 3 weeks ago. The results from the Australian Health Survey, 10,000 people across Australia aged 12 and over, done using the standardised assay that we know is very accurate. So we can see that in Western Australia in summer, 13% of people have levels less than 50 nanomoles per litre. So you can say that's not too bad, or you can say 13% is too much. But in winter it goes up to 28%, and my guess would be that the majority of those 28% are down here in the southern part of Western Australia. Over here in Canberra, wintertime, 49% of us are vitamin D deficient. That's at least partly because it's cold and we don't expose any skin. But it's great to have these data. These are the first data that we can really believe about vitamin D deficiency in Australia. However, you can't have decreasing sun exposure without also having decreasing vitamin D levels. We don't have any data on this in Australia, so these are data from Sweden actually. But they also show, again, this is actually the risk of being, or the likelihood of being over 75. And essentially it shows that over time, as sun exposure has been decreasing, so have vitamin D levels. We're out in the sun less. So why do we care about vitamin D? What vitamin D does is it maintains a constant level of calcium in the blood. And calcium is really important for just the way our cells function. So what happens, vitamin D encourages the absorption of calcium in the gut, and it stops the kidney from excreting any calcium, so it tries to hold the calcium in the body. When there's not enough calcium in the diet for vitamin D to work properly, to actually absorb that calcium, then what happens is that the calcium gets sucked out of our bones. And in rickets, this is what happens. You get these little holes in the bone where the mineral has been taken out of the bone to make sure that the blood level stays where we want it to be. The bones get weak, and we get these classical pictures of knocked knees, bandy legs. They have lots of fractures. They also have problems with immune function. So this is severe vitamin D deficiency. In kids it's called rickets, in adults it's called osteomalacia. But it's basically loss of the bone mineral in an attempt to keep our calcium levels normal. So that was the story. Rickets has been around. People have known about rickets for a couple of 100 years. But in about the last 10 to 15 years, people have become really interested in vitamin D because they think it might be related to a whole lot of these other diseases. And in the last 10 to 15 years, vitamin D deficiency has been suggested to be a risk factor for just about any disease that you can name. So this is not a comprehensive list. There wouldn't be room on the slide. Lots of cancers are thought to be, several studies show that people, or many studies show that people with these diseases have lower vitamin D levels than people without those diseases. The same for autoimmune diseases like multiple sclerosis and type 1 diabetes. And for these diseases, if you have a low level a long time ago, 20 years ago, you have a decreased risk of developing the disease. So a whole range of other diseases. The one I've left off here, the other main one, is infections. The trouble is that for most of these diseases, when you give people a vitamin D supplement, you don't change the risk of disease. So what we see is the people with the disease have low vitamin D levels, but when you give them vitamin D, you don't change the risk of disease. So trying to work out why that is happening is challenging. And there's a question about whether the disease causes the low vitamin D, and really that's what we're seeing, that vitamin D is not the cause, vitamin D deficiency is not the cause, or whether the vitamin D deficiency, the low vitamin D levels, is actually a marker for something else. So you can imagine that people who don't have as healthy a lifestyle, they don't get outside as much, they have low vitamin D levels, and they might be also at increased risk from some of these diseases. So it's hard to know whether it's really a vitamin D effect or whether it's just vitamin D's association with those other parts of healthy life. That's a question we're still working out. Somebody asked me this morning on the radio, are there risks of higher levels of vitamin D? And we do know that in the short term you can give very high dose vitamin D supplementation to people and it doesn't make them sick. But there are a few studies coming out which show these U-shaped relationships where you get a decreasing risk of the disease up to a certain point of vitamin D level, and as the vitamin D level continues to increase, you actually start to get an increasing risk. So this is not, we can't take vitamin D lightly. It's not about just take more and more and more. There actually might be some risks of getting your levels up really high, and we need to just, it's just not something you can take lightly. You need to really be thinking about trying to make sure you're above the 50, but maybe not that you're over the 100. So I'll finally get on to what I'm supposed to be talking about. So this is our problem. We've got the highest skin cancer incidence in the world, but 23% of us across all of Australia, across all seasons, have vitamin D deficiency, and some of us believe that there might be other beneficial effects of sun exposure that are not related to vitamin D. So how do you get the balance? How do you decrease your skin cancer risk but make sure that you keep your vitamin D up? I think it's useful to think about the timing of these things. When we talk about our vitamin D level, we're talking about our very recent sun exposure. The last 4 to 6 weeks is what influences our vitamin D level. But our skin cancer risk, my skin cancer risk, I incurred most of that through a very sunny childhood. Ongoing, the sun exposure I have now is also contributing, but that high dose sun exposure I had in my first 20 or 25 years has already set me at high risk of skin cancer. It's just useful to keep in mind that they are actually on different time courses. So what determines our skin cancer risk and our vitamin D? Our vitamin D dose, or our UV dose of sun exposure, that depends on the UV level, how sunny it is out there, and that varies by the time of day, obviously. There's more in the summer and there's less in the winter. There's more on fine days than there is on cloudy days, and of course the time of day as well. So the sunniest period of the day is in the middle of the day. And then no matter what's out there, if we're in here, we're not getting anything. So it's about our time in the sun. So our UV dose determines our skin cancer risk. What's important, I think, for our vitamin D status is it also depends on how much skin we expose. So if you have a lot of skin exposed, you only need a low UV dose to make your vitamin D, but your low UV dose is what any particular cell gets and won't cause the DNA mutations that you get with a high dose. So I'll build on that. And then we have these modifiers of the balance between skin cancer and vitamin D. age, older people can't make vitamin D as well. Our genetic makeup probably determines our need for vitamin D. Our skin colour might determine how much vitamin D we can make for any amount of sun exposure, and our use of sun protection. So you can see those modifiers here. Clothing's pretty good, blocks out both our skin cancer risk and our vitamin D production. Sunscreen's interesting. It does. Most of us don't put sunscreen on very thickly as it really needs to be to satisfy its SPF of 30 or 50 or whatever we're using. But the studies that have been done show that the way you normally put it on, it doesn't actually change the amount of vitamin D that you make very much. And even if you put it on at the recommended thickness, it decreases but doesn't stop your vitamin D production. So wanting to get vitamin D is not an excuse not to use sunscreen. And shade provides good protection. The closer you are to the trunk, the less UV you get, but you do actually get quite a lot of scattered UV, and you can still make vitamin D under shade like this. Of course, there are groups that are at particular risk of vitamin D deficiency. We know that very dark-skinned people, particularly if they also wear a lot of clothing, are at increased risk, tend to have low vitamin D levels. Some of that is probably a skin pigmentation effect, but there are also cultural influences like not wanting to have a dark skin. You often see Asian people who are wearing umbrellas or are protecting themselves, and that's actually a preference for not having their skin any darker. And so people with darker skin tend to have lower vitamin D levels, but it's not just a production issue, it's actually also a preference issue. I talked about the elderly, office workers, because we don't get outside, we don't have any time in the sun, and extreme sun protection, such as this, all increase our risk of being vitamin D deficient. There's lots that we don't know about how much sun exposure you need to make vitamin D. We think that there's a lot of individual variability in how much sun's required or how much vitamin D supplementation is required to change your level of vitamin D. What we do know is that if you start with a lower level, you go up more quickly with sun exposure or vitamin D supplementation. We know that a higher dose increases the vitamin D production to a point, but if you get a very extreme dose, it actually doesn't increase it anymore. So it's in the sort of low to moderate. You get an increase in vitamin D production as the UV dose increases, but then with a very high UV dose, you don't get a further increase. If you have regular sun exposure, you get this sort of effect. This is the variability in people's vitamin D levels, and these people got sun exposure 3 times a week, but they didn't just keep going in a straight line. They actually reached a plateau at about 75 nanomoles per litre. So you sort of saturate, even if you have regular sun exposure, you reach a level which is your level, and you don't tend to keep on going up. We also know that prolonged sun exposure, so if you just stay out sunbaking, what happens is that the UV, once you've made some vitamin D, if you stay out longer, the UVA actually starts to break down the vitamin D that you've made. So you don't want to go out and stay out. Sunbaking's off. You need to just go out and make your vitamin D and then go inside and let it be absorbed and get into your bloodstream. So where does that lead us? You can't make a blanket rule. So somebody sent me a paper recently to say that GPs should be advising their patients that they should have 10 to 15 minutes 3 times a week in Australia. Well, what's right for Darwin's not right for Hobart. What's right for summer's not right for winter. What's right for a fair-skinned person is not the same as what's right for a dark-skinned person. So those blanket rules you see, they're just nonsense. It just doesn't make any sense. What we need to do is we need to understand the UV index. And I'm going to show you some stuff about the UV index, but it's the only thing that we have which tells us how much UV is out there. And we need to learn about what the UV index means for our skin and be guided by the UV index, because that's forecast every day. It's in your paper, and you can tell from that what the UV index is going to be at different times of the day, and that should give you a guide to your sun exposure behaviour. Based on what I've said before, I think we need to change the way we expose ourselves in the sun. So we should be having frequent, several times a day, going out and having 10 or 15 minutes or 5 or 10 minutes, but brief sun exposures. Going to get your coffee, going to get your sandwich at lunchtime. Protect your head and neck. Those are the places where you get your skin cancers. But otherwise, expose as much skin as you can. And if you can't, like in Canberra, then you're going to have to take a vitamin D supplement. Nobody's going to expose their skin in Canberra in the middle of winter. If you get out and be physically active, like kids in the playground or kids playing team sports in the wintertime, they're active, they get their T-shirts, just T-shirts on, shorts. Children in Tasmania in the middle of winter continue to make vitamin D if they're physically active outside. So you can still make vitamin D even when the UV levels are low if you get out there and get some exercise. So this is the UV index. This was the UV index picture for Perth on Saturday. And so you can see that this is pretty typical for how UV increases to the middle of the day, and then it starts to decrease again. And the colours give you a guide of what sort of sun protection you should use. This is the... one thing you can't get on the internet is you can't ask for Perth in January. They don't seem to have those records anymore. So this is an old one that I happen to have of Denham, and you can see the extreme UV index in, this is the 6th of February 2013, how it's very, very high. So where it's green here, the UV index is less than 3, and even a very fair-skinned person should be able to go out, spend time outdoors and not need to use sun protection. Once it gets to be more than 3, and here I have to confess I'm going to differ from the Cancer Council. Once it gets to be more than 3, go out for 10 to 15 minutes, protect your head and neck, expose some skin, but it's okay to be outside for 10 or 15 minutes and you'll get your vitamin D. If you're going to be out for longer, then you need to use all the sun protection. So you need to slip, slop, slap, sleek and slide. But you can be out during this time if you promise to only be out for a short period of time. The trick is that people go out even in the middle of the day when you make your vitamin D really, really quickly, but they only need to be out for a few minutes, and they go, oh, it's so nice out here, I'm just going to stay out there, and then they get sunburned. So you can see the variability in why one message doesn't work. This is just for Western Australia. You see again Perth down here, and up in Broome, they're still getting lots of UV in the middle of the day. They're still getting high intensity UV. So you can't make a message that is right for Broome and that's right for Perth in terms of minutes outside, but you can do it in relation to the UV index, and that's why we have to learn about it, and we have to learn about what's right for our skin in relation to the UV index. If you want to know where the UV index is, it's at this website. It's also on the ARPANSA website for other places in Australia. And these slides will be available on the Cancer Council website, so you don't need to write that down. This is a slide from New Zealand. They use the same UV index, but they use your shadow. So if your shadow is more than twice as long as you, then the UV index is less than 3. So if you haven't looked at the UV index, you can get it from your shadow. If the shadow is the same length of as you, then as you can see, it's less than 6. And what they say in New Zealand is if it's less than 6, then you can be outside for 30 minutes without sun protection. But if you're going to be outside for longer, you need to use sun protection. So the messages are a little bit different all around the place, which is very confusing. But you can use your shadow as a bit of a guide if you haven't looked up the UV index. This is a bit complicated, this slide, but basically what it's trying to show is that if you have more skin exposed, then you don't need to be outside for as long a period of time. So this is the amount of UV. If you stay out for this amount of time, then you will get sunburn with this UV index. So say we just take a UV index of 8. Then for a person with skin type 2, you need to be out for, I don't know what that is, 30 minutes if the UV index is 8. You can get your vitamin D if you've got your whole body exposed in about 2 minutes. But if you only expose your face and hands, you have to be out for more like 15 minutes, and then you're starting to get close to this period of time where you'll get sunburn. So the more skin you can expose, you increase your safety margin. Don't be fooled by heat. The Victorian Cancer Council has their little motto this summer of it's UV, not heat. So if you look at the UV during the day, just like the UV index, it goes up and then it's highest around solar noon. But what happens with heat is that its maximum is actually late in the afternoon. So you get to this part of the day and you go, oh yeah, it's not that hot outside. I'll be fine. I don't need sun protection now. It's actually, heat's infrared. It's not UV. So you get to late in the day and you go, oh, it's really hot out there. It's really sunny. I better use sun protection late in the day, but actually it was early in the day when you needed to use the sun protection. You can't, again, you need to be guided by the UV index. Don't look outside and say it's sunny or it's cloudy. Who's been burnt on a cloudy day? It still comes through. So you do need to be guided by the UV index, not these things that we think of as proxies like heat. And that's pretty much what I've said. If the UV index is less than 3, just go outside and enjoy yourself. If it's more than 3, if you're just going to be out for a short time, go and enjoy it. Protect your head and neck. If you are going to be out, planning to be out for longer, then you need to be using proper sun protection. There's lots we still don't know. There's lots of research ongoing that we don't know. I'm delighted to be moving from Canberra to Perth to the Telethon Kids Institute, and we have a new project there that we're calling the D-Light project, and it's really looking at risks, benefits and balance, because there's a great group of people in Western Australia working with the cancer councils to try and unpick what some of the outstanding questions are, and then to try and get some good evidence to guide people so that the next time I come and talk to you, I can actually give you something that's a bit, got a bit more meat on it. We're also doing a study across Australia called the Sun Exposure and Vitamin D Supplementation Study, and this is specifically to try and look at whether there really are benefits of sun exposure that are not related to vitamin D. If it's only vitamin D, I can say to you, stay out of the sun and just take a vitamin D supplement. Then you won't get skin cancer and your vitamin D will be okay. But if there are other things that you can get, and we know that there are some effects through UVA, and we think that there might be some beneficial effects for diseases like multiple sclerosis of actually having sun exposure, not through vitamin D, through other pathways. If that's true, then what we actually have to do is fix the sun exposure message. We have to better understand how to let people get that optimal level of sun exposure. So we don't know those answers yet, but we are actively working on them. Thank you.
There's time actually for about 5 minutes worth of questions. So we have a mic here.
Thank you. Excuse me, I have heard that maybe with older people, around 70 or something, their skin has a decreasing ability to produce vitamin D, so they might need more sun exposure or supplementation. What do you think about that?
So there are some studies that have shown that older people have less of the precursor in their skin cells. That said, there is a study that was done in New Zealand quite a long time ago now, but elderly people in nursing homes, they sat them out under the eaves, under the shaded thing, I think on a regular basis, like 3 times a week for half an hour at a time or something, with not getting sunburnt at all, and it increased their vitamin D levels very effectively. So I think what happens with older people, they do tend to have lower vitamin D levels. Part of that, particularly in Australia, is they've been diagnosed with skin cancers, and so they become sun avoidant. So it's often really hard to unpick how much it's actually effective of less of the precursor in the skin and how much it's a behavioural thing.
Maybe they need less too.
And maybe they need less, yeah.
What about exposure to the sun while you're driving? Is that the same as being outdoor?
It's not. So the UVB radiation that you need for vitamin D doesn't pass through most glass. So you can't sit inside and with the window up, you'll get UVA. So you can still get a UVA reddening of the skin from being inside in glass, but you won't make any vitamin D.
Good afternoon. This is probably a politically incorrect question, but is the Cancer Council studying the sunscreen itself? Because my worry is the toxicity of a lot of sunscreens, because you're recommending sunscreen, but there are massive, massive range of sunscreens that are coming from all around the world, and we don't actually know what's in them. All we've got is an SPF guide to go by. Our skin is the biggest organ in our body. What we put on our skin affects our body.
Absolutely. So sunscreen is always a sort of a second line thing. So if you can sun protect in other ways, do. When I send my gorgeous, blonde, fair-skinned son out on the cricket field for 4 or 5 hours, fully, clothed with clothing like this, he can wear sunscreen. He's already had 2 moles taken off, so he definitely, I do care what's in it, obviously, but if you have to use it to protect yourself, then I'd still say use it.
I just want to know about the relationship between taking fish oil supplements, whether there is any benefit in vitamin D through that, sorry, I'm shouting. Did you hear me?
Yep.
Or the other is in regard to cod liver oil supplements, which often have A and D added to them anyhow.
So cod liver oil naturally is high in vitamin D, but also in vitamin A. And I think if you're taking a little bit of cod liver oil supplementation, that's fine. You get your A and your D. If you take a lot, you get too much A is the problem with cod liver oil. To my surprise, when I was looking up the vitamin D content of various supplements, fish oil by itself has lots of omega-3 and other good things. Actually doesn't have vitamin D in it, unless it's fish oil plus vitamin D. So that was an assumption that I'd also had, but it's actually not so.
You mentioned fish and meat. Can you get vitamin D from any fish?
So vitamin D, you can get a lot of vitamin D in irradiated mushrooms. It depends whether you irradiate them with the gills up or the gills down. But if you irradiate them with the gills up, then they have lots and lots of vitamin D. There's not a lot of vitamin D in other plants. This is actually something that I'm exploring with some others within the D-Light project, as to whether you can, in very high ambient UV conditions where it's really, really sunny, if you grow plants in those conditions, whether you can increase the vitamin D that the plants make, and then you can feed those to cows or, other animals, and increase the vitamin D content of the meat. And so you can do it with chicken feed, apparently. You can increase the vitamin D content of the eggs by doing this. So under active investigation, but I don't know the answer.
Sorry. My husband's a plumber and he's worked outside most of his life, and at least twice a day, he applies skin cream, sunscreen, wears a hat, covers himself up, etc. He's been diagnosed with Bowen's disease. He has 2 or 3 times a year he goes to the skin clinic and has various skin cancers cut out. My question is that no matter how much sunscreen he puts on and how often he uses it, is it still likely that with Bowen's disease it's never going to actually really protect him? Or, is there any more that he can do to protect himself?
So he's probably got a high risk from what he's had over his life course of his sun exposure. What can he do to protect himself really is just the physical protection. Keep on doing the things that he's doing and try to not get any more. But, what he's already had in his life is putting him at a higher risk of having these diseases. So all he can do, I think, is continue to sun protect so that if UV is having an effect of actually pushing those potential tumours over the edge to become real tumours, that he can try and block that part of it. Okay.
That's probably the last question we have time for. So would you please join me in thanking Robyn Lucas for a great talk? Thank you.